My name is Dr. Malo, and our next lecture we are going to talk about mechanisms of edema. But before we continue with the mechanisms of edema, I want us to remind ourselves, we recap on what we did in our first lecture. So in our first lecture, we talked about definition of edema, and we said that the definition of the edema, it is the excessive amount of fluid in the body tissues extravascularly and or serous body cavities. And to explain this definition, we said that the serous body cavities, for example, when there is excess amount of fluid in the pericardial cavity, we say it is pericardial effusion, that is edema. And when we say that there is excess amount of fluid in the peritoneal cavity, we say that one is hydroperitoneum or ascites. To our definition and how edema happens, how edema comes about, we need to know the normal amount of body fluid in different body compartments. Normal amount of fluid in different body compartments. So let us have a simple diagram. For example, this is our tissue. This is the tissue. So first, let's say mechanisms, edema. But before that, let us have our tissue, small tissue, to explain this concept and you get it clearly. Remember, this is our left side of the heart, and then this is the arterial system. This is the arterial, and then the meta-arterial, and then the capillary system, the microcirculation, and then this is the venous end that now drains blood back into the right heart, and then the pulmonary system, pulmonary artery will take this blood into the lungs for purification. And remember, there is also microcirculation in the lungs, and then it will be taken back, the oxygenated blood taken back into the left side of that by the pulmonary vein. So let us say this is our tissue. Our tissue, we have our serous body cavity, and we have parenchymal cells. We have our parenchymal cells. So we say, for example, the total body weight, in our case, we have the lean body mass and total body water. The lean body mass, what we said in our first lecture, is always 40% of total body weight, and total body water is always 60% of total body weight. And we say that the amount of water, body water, is determined by total body weight. Let us say, for example, we have a patient who is 72. Let us do a recap who is 72 kg. 72 kg, when we calculate, this person will have total body water 42 liters. 42 liters, and we said that this 42 liters is both in the intracellular and extracellular space. The total body water, intracellular and extracellular. The intracellular is always 2/3 of total body water, which when we calculate, it will be 28 liters. So let us assume, let us say the intracellular is 28 liters, to mean that the remaining amount of water, when we subtract from 42, it will be around 42 to 14 liters, both the plasma and the interstitium. This is a normal case. But due to some reasons, when we try to talk about mechanisms of edema, due to some reasons, pathological reasons, how edema result, or because in medical school or our doctors, we normally refer to the interstitial edema most of the time. But remember, we have intracellular edema and also we have the extracellular edema. The excess fluid in the microcirculation in the vascular system is not considered as edema. I explained it yesterday. Maybe when you check on my first lecture, you see how I was explaining the hyperemesis and the congestion, how it occurs. So this fluid, remember, this body fluid is being regulated by some two hydrodynamic forces. One of these forces, we talk of hydrostatic pressure. In case, for example, this hydrostatic pressure is being generated when the heart pumps, and it is usually when it is the microcirculation is 35 millimeter of mercury in normal case. And the oncotic pressure, which is always also being determined by the level of plasma protein. And plasma protein, we have globulin, the plasma protein. We have globulin, we have fibrinogen, and then we have the albumin. So the major or the classic type of plasma protein we focus on is albumin. So this albumin is what determines the oncotic pressure. And in our normal case, it's always 25 millimeter of mercury. So we say that this oncotic pressure helps to suck fluid, and the hydrostatic pressure is always act as a pusher. It will push fluid to the membrane, the capillary membrane, and the capillary membrane is semi-permeable. So we say that the net filtration pressure that will help to push some fluid out from the circulatory system is 10 millimeter of mercury. So this is a fluid that is always normal in the interstitial space, and this is a fluid that is considered dynamic. It does change. Remember, this fluid comes with the glucose, it comes with the amino acids, it comes some of even the albumin or that. So the albumin, even the fibrinogen, some of the fibrinogen. This glucose and the amino acid helps the functionality of the parenchymal cells, because remember, we have a specific type of a special type of pump called sodium ATPase. Sodium ATPase is always in every cell. Sodium ATPase is always in every cell, but for the mechanism to continue, it must have glucose, and these cells are being fed by some fluids that are coming with the components. These cells are being fed by the glucose to generate energy, at least to facilitate the sodium potassium pump sodium potassium pump. So there will be some fluid coming to the interstitial space in normal case. Let us assume due to some specific reasons, pathological reasons, or like we have an obstruction in the venous system, we talk of maybe DVT that leads to increase of hydrostatic pressure. So let us assume that this hydrostatic pressure, due to the obstruction, the hydrostatic pressure increased to 45 millimeter of mercury. Remember, the oncotic pressure is constant, because this one, it doesn't deal with anything like alumina. In this case, this one we are still talking about the hydrostatic pressure and how the edema now result due to pathological reasons. For example, maybe in DVT. We find that now the net filtration pressure will be 20 millimeter of mercury, and that clearly means that excess amount of fluid will escape to the capillary membrane. So we'll have a lot of fluid in the capillary system, in the interstitium. So that's number one mechanism of edema, increased hydrostatic pressure. So we say that increased hydrostatic pressure occurs when there is increased net filtration pressure and reduced reabsorption the reabsorption rate. So we say net filtration pressure, when it is increased, there is excess amount of fluid that is pushed in the interstitium, but the reabsorption rate is also reduced due to obstruction. That one is hydrostatic pressure. That's not one mechanism. Number two, we talk of reduced colloid oncotic pressure. This type of pressure is being determined by the level of albumin in the microcirculation. This type of albumin is being synthesized in the liver. So when there is reduced albumin, we say hypoalbuminemia. Hypoalbuminemia. That determine this level of pressure, we say that the pressure will reduce. So when the pressure at this point reduces, to say that maybe it is 15 now, or maybe it is 10, the oncotic pressure has decreased, to mean that it will not have that capability of sucking fluid that is going out into the interstitium. Therefore, a lot of fluids will be going into the interstitial space. And remember, when the oncotic pressure is reduced, a lot of fluids, it won't be able to suck fluids back. It won't be able to suck fluid back for the maybe when you talk of in a normal case. In a pathological case, in an abnormal case, it won't be able to suck the fluid back because of the level of albumin, the colloid oncotic pressure. Are we together? Number three of mechanisms of edema when there is capillary damage. So maybe when we talk of increased capillary permeability, this one, remember, when there is increased capillary permeability, also the excess fluid will come into the interstitium. And remember, when the fluids are coming into the interstitium, there's a sodium that will try to trap water together into the interstitial space. Number four, due to lymphatic obstruction. Or impairment of lymphatic drainage. This one occur, for example, remember there are some components that normally escape due to the capillary membrane is semi-permeable, like the albumin or the fibrinogen total plasma protein. And when they're in the interstitial space, in normal case, this type of protein is normally being drained through the lymphatic system. Yeah, because it can be pushed into the interstitium, but because due to large molecules, there are large molecules that can't be reabsorbed back. They will have to drain through the lymphatic system, and then get back into the heart to the lymphatic system. So in a case where there is an obstruction, or in a case maybe there is a lymph node lymphadenopathy somewhere, or maybe in the case of radiation that has damaged this system, which results to decrease drainage of fluid into the lymphatic system, they will be retained in the interstitial space. And when it is retained in the interstitial space, remember, they will be trapping water into this space, and therefore there will be a lot of fluid trapped into the interstitium. And just to make it very clear, remember we were talking of the oncotic pressure. When the reduction of oncotic pressure when the fluid is coming, but the lymphatic system is okay. When the lymphatic system is okay, meaning the protein that escaped through the capillary membrane will be drained through the lymphatic system. But in a case where it is obstructed, it won't be able to drain to the lymphatic system. Therefore, it will trap a lot of water into the interstitial space. So this to mean the difference between pitting edema and non-pitting edema. Pitting edema, when we say the lymphatic system is okay, but the oncotic pressure is decreased. Therefore, the fluid that will be coming here, for example, if you apply your thumb to assess the edema, when you press and it remains there remains a depression, meaning that we say the water is separated. That doesn't mean that it has protein inside. So a moment when there is protein due to lymphatic obstruction, this water will be sucked or will be absorbed by this protein, and therefore when you apply pressure, you try to press, it won't remain. It won't be pitting. It won't depress, meaning the waters will not separate. That is non-pitting edema. But the pitting edema, when the water separates. So to tell you that when there is non-pitting edema, that one will definitely tell you that there is a problem with the lymphatic system. Therefore, the fluid, the few components, protein that are being leaked, that are being drained to the interstitium, they don't find a route into the lymphatic system. And you say that it can be maybe the lymphatic damage, it can be lymphatic obstruction, maybe in cases of filariasis, the term filarial worms that leads to fibrosis into this system. It can cause the reduction or retention of sodium or retention of protein into this. Remember, the sodium is there, and also sodium traps a lot of water. Therefore, water will be here, but it won't be pitting edema. So that's pitting and non-pitting edema. In this case, before we continue into another mechanism, we also have dependent edema. Dependent edema. This type of edema is being controlled by gravitational force. It depends on the position. Now, for example, when you are in a standing position, the dependent edema, you are in a standing position, the lower extremities will be edematous, meaning this type of edema depends on the gravitational. This is the dependent edema. For example, when someone sits down and you find there is sacral edema, that when you say that it is a dependent edema. Maybe there is an inflammation, edema of the hand, edema of the arm. When you try to elevate it, the edema will resolve, meaning it depends on the gravitational force. Fifth, we are talking of sodium and water retention. When there is sodium water retention, and we normally know that sodium traps a lot of water. When there is sodium water retention in the body, there will be excess accumulation of fluid in the interstitium, because we've said sodium is majorly on the interstitial space. It is not intracellular. It's not, or it's always in the interstitial space. So when there is sodium retention, meaning it will trap a lot of water and it will cause edema in the interstitial space. So to brief you, to make it briefly on the increased hydrostatic pressure, one of the mechanisms that lead to edema, conditions like maybe in heart failure or maybe in DVT, and the colloidal oncotic pressure could be or nephrotic syndrome, and also maybe the capillary permeability. It could be excess, the inflammation or direct injury, and the lymphatic obstruction, sodium and water retention may be due to heart failure. So it's the class of today. We are to cover the mechanisms of edema. We are to cover the mechanisms of edema, and one thing again to make it clear is that the intracellular edema we define it as hypersmolarity that normally occur when there is hypoxia or maybe there is mitochondrial damage, and also maybe when there is direct injury to the cell. Yes, thank you very much. So the class of today, we are to cover the mechanisms of edema. Next class, next lecture, we are going to see the conditions